Guys, after subscribing to this channel, please make sure that you also press the bell icon so that no notification, no new video of mine, any educational video, is missed by anybody.
Okay, let's begin with endometriosis first. There's a huge, discussion to ensue in endometriosis, and still we'll be skipping up so many, topics which are offbeat topics, but which can be asked in your exams. Why? Because the examiners, they're now very sick and tired of asking the same repetitive questions: the medical management, the surgical management, the different theories of development of endometriosis, and the side effects, and endometrioma, complications, scoring, and everything. So now they search for different questions. So has anybody of you seen the Foxy GCPR 2024? How many of you in my class have seen the Foxy GCPR 2024? Because even the NICE guidelines, ESHRE guidelines, they're all old, couple of years old. Foxy, I keep an eye on because you people, you really like Foxy, and lots of examiners, they like to talk about Foxy GCPRs along with AOGD, bulletins. Many people follow that. Lots of questions, in fact, are framed from them. So I would want to ask you, how many of you really know about this Foxy GCPR from my class? How many of you have studied, know about it, that it's the latest, and have any idea about it? Yes, guys, are you not informed, well informed? My students who are going for their theory exam, or are you totally dependent on me? Yes, Umesh, any answer? Anshu, have you seen or not seen? At least give me an answer. Thumbs down if you've not seen. Thumbs up if you have seen and you've not yet read, or not, you don't know much about it. I'm not going to ask any question. Just let me know if you have any idea. Have you seen that there is a Foxy focus on endometriosis? Yes. So what's your answer, Chamte, Umesh, Anshu? Seen? Okay. What about the other two? And where are the others? Swati, what about you? Have you seen the Foxy GCPR? So in this Foxy GCPR, they have, described mostly about the management, like I always emphasize on. They've spoken about, the endometriosis in adolescents. They've spoken about deep endometriosis. They have spoken about, of course, the medical management is in quite detail, which I will also teach you. And then they've spoken about recurrent endometriosis, and I saw this question twice, recurrent endometriosis. Then they have a very nice, algorithm. Now, just do this basic, which I'm doing with you today, and quickly go through the flowcharts and a couple of things which are given in Foxy Focus. I'll be putting that Foxy Focus as well in your revision blitz group. Why am I saying that is because this is already 50 slides presentation. It will be at least 25 more with all those topics. Plus, they're offbeat topics. Since a question has been asked on them, it does not make them core fundamental topics. Okay? So here I'm going to tell you the core fundamental, what makes endometriosis and where you have to focus, which has got a very high potential of being asked in your exams, both practical and Viva in different ways, which can even come in OSCE, table Viva, and of course, your as a CPP, chronic pelvic pain, case in your examination. At the same time, lots of theory questions can be formulated in it. But like I said, the examiners are now irritated with the old questions. So that's why they're searching these newer ways. So anything new that comes, they ask, especially in recent advances paper number 4. So here you can focus on the Foxy. Starting with endometriosis, it's an estrogen-dependent, benign, inflammatory condition, correct? So endometrial glands and the stroma, they are found outside the uterine cavity. This is the reason why they have the bleeding of these endometriotic lesions and therefore pain. The lesions are typically located mostly in the pelvis and they occur at multiple sites, but you usually will find them in the dependent position, mostly in ranking of decreasing order of frequency ovaries, anterior posterior cul-de-sac, posterior broad ligaments, uterosacral ligaments, fallopian tubes, and round ligaments. Okay. Factors increasing the risk of endometriosis are nulliparity, prolonged exposure to endogenous estrogens. You know what are the risk factors of endometriosis? Quickly tell me, guys. Now, come on. I want you to be active, and I'm not going to spoon feed you all the time. So I want everyone to answer. Sujata, Swati, Chante, Umesh, Anshu, everyone, quickly tell me, what are the risk factors? Where do you find most of endometriosis? Yes. So please read the Foxy Focus. It's very, very simple, very interesting, nicely given, and they have lots of diagrams, flow charts, and this tables. So just, and certain offbeat topics which you'll not find anywhere else, right? Yeah. Now tell me, what are the risk factors for endometriosis? Yes, Sujata, absolutely. Hyperestrogenic states. Quickly tell me what else? Nulliparity, early menarche, late menopause. What else? Obesity. Okay. What else? Okay. Certain races are also predilection for endometriosis, and it's, no one is going to basically ask you that, but you have any patient who is, in the reproductive age groups and infertile, coming with pain abdomen and has had this kind of cycles ever before. So you can think in terms of endometriosis as well. Now, what are the speculations? What are different theories which we know about? One is ectopic transplantation, that the endometrial tissue through the transtubal, regurgitation got implanted in the, during menstruation got implanted in the pelvic cavity, and you have robust evidence because the uterus, while you're lying down and everything, is like retroverted or at least falling down on the organs, and because of that the ovaries are highly affected, and so is the POD, and so is the uterosacrals. Then something is called a coelomic metaplasia, that the coelomic epithelium only got transformed into endometrial tissue. Then there is something called as induction therapy theory. That means certain undifferentiated peritoneal cells, they cultivate into endometrial tissue by themselves, okay, by an indeterminate endogenous biochemical component. So there is an induction automatically of the peritoneal cells to evolve into endometrial components. These are certain theories. And there are a multitude of other factors like immunological factors, inflammatory factors, familial factors, so on and so forth. So usually the patient comes to you with pelvic pain, infertility, or ovarian mass. Yes or no? These are the only three classical presentations. Yes or no? Additionally, endometriosis symptoms, they include bowel and bladder dysfunction, abnormal uterine bleeding, low back pain. These are also, the features you will find in endometriosis. Chronic fatigue, this is all like not very common, but yes. So what do you see in endometriosis? You will see when you're doing a per speculum and per vaginal examination, you will see tenderness in the vaginal fornices. Definitely this part, nodules in the posterior fornix, very specific, very categorical of endometriosis. Adnexal masses, immobility or lateral placement of the cervix or uterus. So you'll see that there are dense adhesions in the uterus is immobile. It will be very, categoric when you're doing this movement of the uterus, and you feel the pouch of Douglas is having some nodules. Okay. Now, so do you have any laboratory parameters? Unfortunately, you should not rely on the laboratory parameters because CA125 is slightly increased because it's an inflammatory condition. And most of the others are not clinically useful. Do you think any imaging result is useful for you guys? Do you think imaging results will give you any benefit? Anyone? Do you believe that you can catch endometriosis through imaging modalities? Yes, guys. Quickly, because we have a long way to go. We have to do adenomyosis as well. And I'm going to give you a lot of information when it comes to management, like I always do. So this initial part, I'm expecting you to give me answers like this, because this is your MBBS level, right? Yes. Answer is no, I do not want to rely on imaging, no matter you go for MRI, you go for anything. They might help if there is endometrioma or obvious lesions, but otherwise just endometriosis, you cannot. And by the way, laparoscopy is no longer the diagnostic gold standard. You do not jump on to give laparoscopy as the mode of choice. Yes? Do you know this, guys? So, abhi people are relying on laparoscopy, but the current version of X-ray states that laparoscopy should be done only when imaging results are inconclusive or where empirical treatment was ineffective, and laparoscopy is no longer the gold standard. Okay? So laparoscopy should be only managed, only done when imaging results do not give you any answer. You tried and did the empirical management. That means you give the COCPs or you give the POPs, Dynogest or whatever. It's not giving you any results. maybe then you can try the laparoscopy, but usually you can't jump on like earlier we used to say this, jump on laparoscopy, do laparoscopy, but now they want to stay back. Do not jump on to do laparoscopy as a diagnostic modality and then start your empirical management. Do the other way around, correct? Because when you do laparoscopy, what classical features do you see which make you feel that this is probably endometriosis? Can you name a few lesions, the name of the lesions which will make you feel that this is endometriosis quickly, guys? Like you must have assisted somebody. Yeah, guys, you must have assisted somebody for endometriosis, this thing in laparoscopy. So I'm sure they must have written down when you're writing this OT notes as to what exactly have you dealt with. So what are the terminologies you usually use to describe endometriotic lesions? One is, okay, powder burn lesions, very good, powder burn lesions. What else? Chocolate cyst, yes. Red lesions, okay, I can take that. Anything else? Okay, kissing ovaries also I'll take. Septation. Septation you'll see inside, right? So you can't exactly mention. Adhesions is a possibility. Yes, I'm talking about the specific endometriotic lesions names, okay? Which I have in this next slide. Flame-like patches. Yes, flame-like patches you must have heard. You must have seen. You must have seen with your own eyes. Yellow-brown discoloration. Even translucent blebs. They are initially endometriotic lesions only. Scarred or puckered surfaces. Isn't it? And your favorite, dense, fibrous adhesions. Yes?